The following podcast is part of a certified educational activity titled Pioneering Precision Medicine in Bladder Cancer, Multidisciplinary Perspectives on Personalizing Patient Care. Access the entire activity and complete the post-test at peerview.com/XJV860. Downloadable slides and practice aids are also available.
Good morning, everyone. Thanks so much for coming in today. Welcome to the SUL. Welcome to this presentation from PeerView Live. I'm Neil Shore. I have a great privilege of having wonderful faculty, Sia Donishman, Guru Sampavde. We have a lot of folks attending virtually. Look forward to this being interactive as much as possible. Our title here, Pioneering Precision Medicine in Bladder Cancer, Multi-D Perspective on Personalizing Patient Care. And I thought to myself, there's a lot of P's in this. But this is bladder cancer, right? So next time we're going to have to add some B's into it. But I still like the alliteration. And what's particularly interesting is, the embarrassment of riches we now have in bladder cancer. And so we're catching up with many other solid tumors now. So again, it speaks to the importance of multidisciplinary care. I'm Neil Shore. Welcome. Thank you for attending. What are our goals today? I've already sort of stated, it's all about personalizing this notion around urothelial cancer. We're not going to have time for upper tract. That's important. We're really going to spend most of it on bladder cancer today. Really going through the entire spectrum in this hour, from NMIBC to muscle-invasive, bladder-sparing, and metastatic. And it's just overwhelming in some ways, but really great, the advances that we have. I personally think if you're a fellow right now or you're early in your career, this is the absolute antidote to any considerations of burnout. If you can't get excited about the things that are happening right now, it just doesn't, it's just a wonderful time. So we're going to review all the different issues. Here's a quick overview going from NMIBC, the high risk, the TAG3s, CIS, T1s. Are you doing your resections appropriately? What are you doing to think about that? And then, of course, we'll go through very, very nicely. Doctors Donishman and Sampavde are going to review from muscle-invasive, neoadjuvant, bladder-sparing, and for our patients with locally advanced and metastatic, what are all the new things that are out there? And there's a lot. So we have unmet needs. This reviews them from underutilization to overutilization of intravesical therapies, BCG shortages, and new therapies that are available to combat that. It's sort of like overtreatment, undertreatment. We want it just right. It's sort of that Goldilocks phenomenon. So we have to do it in a multidisciplinary way, and that's the importance of this slide. And you can read through this. There's so many great approvals, FDA, EMA, globally. It really does require now a team-based approach. But we're here at SUO, and as a uro-oncologist, I think uro-oncology needs to be, front and center, working with our other specialists. I mentioned Beacon here. It's a really trusted resource. Take advantage of this. This is great information for your patients. You can download the QR code, super helpful. So with that, let me toss it over to Dr. Donishman.
Great, thank you so much, Neil. So as Neil said, there's a lot happening in urothelial carcinoma these days, and we're going to go through a whirlwind of all the latest developments. Again, the details of the slides I won't get time to get into, but all the slides will be available to you later. So we're going to start right out and talk about Keynote 57. This was a pembro monotherapy for BCG unresponsive disease. This is the typical high-risk non-muscle invasive bladder cancer. And this was an FDA-approved medication in January 2020. You can see the best response rate with a complete response of 39%. However, you see that the curve sort of tailing at the end. The response rates over a prolonged period of time, 18 months to 24 months, really drops down considerably. So even though we're happy to have this in our armamentarium of treating patients, we still need further therapies. So what's next? A lot of activity in this space. We have the phase 3 Potomac trial. These are large trials, and the Keynote 676, both over 1,000 patients. The Potomac is a BCG induction plus durvalumab, and then comparing that to BCG induction with maintenance plus durva, and BCG induction plus maintenance. So really try to see whether the addition of a checkpoint inhibitor improves the efficacy of BCG. And then Keynote 676 is another phase 3, is basically just adding Pembro to BCG. So we're going to have results of BCG plus checkpoint to see if we can actually improve on the results of BCG for non-muscle invasive bladder cancer. What about phase 1/2's ADAPT is also in this space, BCG unresponsive high-risk non-muscle invasive bladder cancer, and you can see the various cohorts there. Again, comparing durva monotherapy, durva plus BCG, putting in external beam radiation therapy in there as well, versus durva plus gemdosi, really testing out the combinations for the various treatments available to us. So we really look forward to seeing these results, and no question we're going to find a good combination here to improve on the already fairly good results with the agents that we have for primary therapy, but certainly need a lot more in the BCG unresponsive space. So here's what has been presented already. This is or published. This is again in the BCG unresponsive space, with one of the trials being BCG naive. So currently we do have sequential gemcitabine and docetaxel as our sort of rescue therapy. This is results from retrospective studies showing approximately 58% recurrence-free survival at 2 years. And for CIS with or without papillary disease is about 50% recurrence-free survival at 2 years. So currently, if patients are not going on trial, this is sort of our rescue therapy if available. The other one that has been getting a lot of attention is this IL-15 superagonist, as was a phase 2/3 study, otherwise known as QUILT. This is again in the same space of the BCG unresponsive disease with CR rates of 71%. So we look forward to that coming on to the market as well. And we do have a fairly recently approved therapy at Adstiladrin or nadofaragene firadenovec as a viral gene transfer phase 3 trial based on this 151 patients with CR rates at 3 months of 59%. Again, we do see a drop-off at 1 year, but nevertheless, this is very well approved, very well tolerated and approved therapy, and just recently became available as an early access program to several centers around the country. So we actually have this in our clinics now at USC, and we're beginning to use Adstiladrin. The advantage is it's a one-time treatment for 3 months, so you get 4 treatments per year, so very, very well tolerated. And then just at the bottom here, we have BCG versus gemdosi. This is in BCG naive patients in a trial called the BRIDGE trial that Max Cates from Johns Hopkins is leading. It's a cooperative group trial that many of us are participating in. So we're going to see whether gemdosi can be brought up front as the induction therapy. So busy slide, but just wanted to highlight this as well. This is cretostimogene grenadenorepvec. I think I said that right, or it's otherwise known as CG0070. This is an oncolytic adenovirus. It's a vaccine essentially engineered to produce GM-CSF and replicate in selectively tumor cells that are exhibiting or mutated in deficient RB pathway, which is present in many bladder cancer cells. Completely new mechanism. There's been some great preliminary data from the phase 2 Core 1 trial with the CG plus Pembro in high-risk BCG unresponsive non-muscle invasive bladder cancer with CIS, with CR rates up to 85%. Again, also very well tolerated. Okay, so let's move on to another sort of delivery mechanism and a very exciting new therapy. So this is otherwise affectionately known as the pretzel. This is the TAR-200 program in the Sunrise trials. There's Sunrise 1 through 4 currently, with another one, Sunrise 5, opening. So this is a delivery mechanism, enables a sustained release of gemcitabine into the bladder, increases the dwell time. Many of you have seen sort of short videos of this. This is placed in the clinic, in the bladder. The device floats in the bladder as the size of 2 quarters, and it elutes gemcitabine over a period of time. In this case, would be 3 weeks. So this was the Sunrise 2 trial. I presented this at the AUA in May, and there was updated results presented by Andrea Necki at ESMO just recently. So the one that was being presented is just the cohort 2, the TAR-200 alone. 80 patients supposed to be in this trial, primary endpoint being overall CR rate. As you can see, there was a cohort 1 with citrilimab, which is a PD-1 inhibitor, a cohort 3, which was citrilimab alone, and these two were closed once we saw the results of cohort 2 being so good. And this is the presentation at ESMO. You can see that 23 patients presented CR rates of 76.7%. If it was investigator assessed, it was 80%. These are not numbers we're used to in non-muscle invasive bladder cancer in the BCG unresponsive space. So importantly, many of these were sustained. We have about 6 patients right now who are over a year in treatment. I have several of those patients. This device is very, very well tolerated in the bladder. So we're very excited about the various Sunrise trials here and making this part of our armamentarium in the treatment of disease across the spectrum of disease states. So I'll highlight another one. Sunrise 3 is going head-to-head with BCG in BCG-naive high-risk non-muscle invasive bladder cancer. The key eligibility criteria is the same as for all patients receiving BCG, but basically Group A gets TAR-200 alone plus citrilimab, Group B gets BCG, and then Group C gets TAR-200 alone. So we'll see, again, this is another one of those trials that is going head-to-head with BCG, so that particularly in this era of BCG shortage, we have other treatment options available to us. This is a hot topic as well, FGFR3, particularly mutations that are frequently observed in bladder cancer. You can see they're actually expressed throughout the spectrum of disease, from non-muscle invasive to metastatic disease, and particularly in the upper tract, where mutation rates tend to be much higher. But these FGFR3 inhibitors are now available, and they're effective across the disease spectrum, from low-grade disease, where we see actually increased expression, all the way to metastatic disease, where we lose some of these mutations that are present. So this has been the subject of several trials. This is the THOR-2 trial, which is using oral erdafitinib, which is an FGFR3 inhibitor, versus intravesical chemotherapy, again, in the BCG unresponsive high-risk non-muscle invasive bladder cancer. Again, multiple cohorts. In this, it was papillary tumor, papillary plus with or without CIS. And then there was a cohort 3, which it was interesting, which was giving an oral medication to patients with recurrent low-grade Ta tumors, or the intermediate risk AUA, intermediate risk patients. So you can see that the curve sort of separating. Erdafitinib did far better than the chemotherapy for high-risk non-muscle invasive bladder cancer. And then the cohort 3, again, was just an exploratory cohort. These are low-grade tumors, and you can see there was CR in 6 of 8 patients. And by CR, I mean we had to leave a marker lesion behind, and we gave the oral erdafitinib. Then we would look in at 6 weeks, and then 3 months, and these lesions were literally disappearing. We have a great picture of this. So we know this is highly effective even in low-grade tumors. So these drugs have a lot of side effects, and it only makes sense to move from oral therapy, systemic therapy in non-muscle invasive bladder cancer, to sustained delivery inside the bladder, and that's exactly what's happening. So TAR-210 is another one of those pretzel devices that now has erdafitinib inside the pretzel, and that cohort 1, again, in this would be the high-risk non-muscle invasive bladder cancer patients or BCG experience, and cohort 3 would be that intermediate risk patients with recurrent low-grade only Ta or T1 disease. You're not going to see low-grade T1, but essentially low-grade Ta. There are lots of these patients around who keep forming these tumors. It gets really frustrating for both patients and providers to keep taking the patient back to the operating room for the TURBTs. So this was a phase 1, essentially, because this is a novel delivery mechanism with a drug inside the pretzel. and this is being tested. And I can tell you that already the results are pretty spectacular, actually. We're seeing recurrence-free rates of 82%. These are the two different sort of doses, and we're seeing that essentially the same response. So we have very, very high CR rates, 87% in FGFR3 altered intermediate risk patients. The reason you're seeing these high CR rates here with the low-grade tumors is because the FGFR mutation is seen far more often in low-grade tumors. So they're highly, highly effective. And now you're delivering the medication directly in the bladder, significantly reducing the side effect profile of the drug. And this is, again, very well tolerated. And this one is a 3-month formulation. So you put this drug device in the bladder and it stays there for 3 months. So again, super exciting. You can see the treatment-related adverse events here. Very, very few. We're all very used to these irritative voiding symptoms that we see with any medication or even with just recent surgery. So very few serious adverse events here. So a little bit about muscle-invasive bladder cancer now, recent advances. And most of the advances have to do with perioperative management and neoadjuvant therapy. Again, there's another Sunrise trial here. It's a phase 3 trial testing citralumab, again, a PD-1 inhibitor, plus the TAR-200 device. Again, that's gemcitabine within that pretzel device every 3 weeks for the first 18 weeks. And testing it out with standard of care chemoradiation therapy for muscle-invasive bladder cancer. So this is two very different treatments options for bladder preservation for muscle-invasive bladder cancer. This is accruing very well globally. I have several patients on this trial, and again, very well tolerated. So this is essentially the same treatment as we're doing in some of the other trials. So we look forward to seeing these results and seeing if this has activity in muscle-invasive bladder cancer as well. What about trimodality therapy? Of course, that's an established treatment modality. We have another trial seeing whether the addition of pembrolizumab to this usual chemoradiation therapy actually makes a difference. Simple study design here. You're going to add pembro versus placebo, and then do the assessments along the way to see whether the addition of a checkpoint inhibitor actually helps with chemoradiation. We hope to see improvement in bladder preservation trials as well. What about neoadjuvant chemo or immunotherapy? There's a lot of activity there, as you can imagine. There's a big presentation at ESMO really kind of shifting our entire focus of neoadjuvant sort of concepts because of the metastatic disease response to EV-Pembro. But nevertheless, these trials are ongoing. These are cis-eligible patients. Energize as Gem-Cis-Nivo, Niagara as Gem-Cis-Durva. We have Keynote 866, Gem-Cis-Pembro, and then, of course, the Keynote B15, EV304, is Pembro-EV in the neoadjuvant space. So, again, we're going to see improvements with CR rates and seeing whether we can actually preserve some bladders following neoadjuvant chemotherapy. There's neoadjuvant immunotherapy as well. There's a Keynote, again, I mentioned that the Pembro, this is for cis-ineligible patients. Now we have the EV-Pembro because that doesn't really matter. That we were seeing similar responses in metastatic disease with EV-Pembro. We have the Volga trial, which is Durva plus tremelimumab and EV. And then there's another Sunrise trial here, the phase 2, which is TAR-200 plus citralumab in cis-ineligible patients. So we'll see what this all shakes out. But obviously, we're going to see some of these agents move on into the earlier space and then neoadjuvant. And then the next question is going to be, do we need to actually take out these bladders or do some kind of consolidation therapy for these patients who have CR? What about adjuvant trials? There are 3 major adjuvant trials that have recently been either presented or completed. So the IMvigor010 was the first one to complete and get published. This was atezolizumab versus observation. The primary disease endpoint was disease-free survival. And unfortunately, this did not meet the DFS primary endpoint. So we thought with this that adjuvant therapy with immune checkpoint inhibitors may not be the way. However, Checkmate 274 came out. Very, very similar design, Nivo versus placebo, the primary endpoint being the same. And this one actually showed a major difference. I'll show you the curve here. But this did get FDA approved and is our current go-to for patients who have residual disease following cystectomy, following neoadjuvant chemotherapy, or if they're cis ineligible. Now, the Ambassador trial was closed a little bit early once Checkmate 274 resulted, and that was Pembro versus observation with co-primary endpoints of DFS and OS. And the primary endpoint has been met, and there's excitement about seeing the final results here. So we may have 2 approved therapies pretty soon in the adjuvant therapy armamentarium here. So this was Checkmate 274. This is, again, the approved therapy. These are patients with high-risk muscle-invasive bladder cancer or upper tract disease who underwent cystectomy, and they either had YPT2 to YPT4 following neoadjuvant chemotherapy or node-positive disease, or they had PT3 or 4 without prior neoadjuvant, but they were not cis-eligible. So high-risk patient population here, basically they get stratified, get either Nivo or placebo for a year, these are the updated DFS results that was fairly recently presented by Matt Galsky. So this is the intent to treat population. You can see that there's a separation of the curves going out to 5 years. We still don't have the OS data, but we do have disease-free survival here being significantly different. Again, approved in the U.S. for adjuvant therapy, and we're currently using this as our go-to. So here's your treatment algorithm. You get your patient evaluation, whether they're a radical cystectomy candidate, if they're not willing, or want to have bladder preservation. TMT is our current approved therapy, clinical trials plus minus IO. And then, of course, all the various combinations that we talked about here. Again, we're really excited to see results of perioperative EV in this space, and enfortumab vedotin, along with Pembro, that we've seen spectacular results of in metastatic disease that we'll hear about a little bit later. So here's a patient, Jonathan, non-muscle invasive bladder cancer. His ECOG performance status is 1, papillary disease. He has FGFR alterations, BCG unresponsive, undergoes repeat TURBT, and has no residual disease. What options does he have? So again, he's sort of not really that old, but his ECOG status is 1, papillary disease, BCG unresponsive, and currently has had his disease resected.
So that was great, Sia. That was a true tour de force covering everything starting from NMIBC to bladder sparing, BCG naive, unresponsive, going into neoadjuvant and even adjuvant in a very short period of time. This particular case is instructive because it speaks to the notion now about checking a biomarker, looking at tissue, and you can do this through tissue or urine-based testing for FGFR alterations. So this whole notion around biomarker and precision-based therapy. And then, as you really nicely went over, all these different opportunities in BCG unresponsive, even with traditional generic intravesical chemotherapies, new delivery device systems that improve dwell time, whether it's with gemcitabine or erdafitinib, is very interesting for urologists. So let me think about this case, Sia, and also Guru, because several questions have popped up. If you're going to be thinking about a patient here for a clinical trial, or if you don't have a clinical trial, so this patient, and several questions about this notion around managing immune-related adverse events, especially for the urologist, and how does the uro-oncologist work better, particularly not only in community, but even in the academic setting. So let me throw this back to you, Sia. In this particular case, what's the conversation you're having with this patient right now? And let's assume you have the clinical trials available at one answer and another one you don't.
Yeah, thanks, Neil. So this patient, certainly we don't want to go to cystectomy. He still has papillary disease. It doesn't really mention whether it's T1 or not. I think there's a lot of nuances here. If the patient had high-grade TA, is actually progressing to T1, is still non-muscle invasive, but it's certainly very high risk. Even with an ECOG-1, I think I would recommend a cystectomy in that patient if they're progressing. Now, presumably this patient is not progressing, has FGFR alteration, and is presenting with another papillary tumor that's high-grade TA. So now currently has no residual disease. In the past, we've really concentrated on patients with CIS, with or without papillary disease. Presumably this patient only has papillary disease that's been resected. So again, if they're not part of a clinical trial or they're not eligible for it, I think our go-to would be gemcitabine docetaxel. That would be the combination therapy. But we do have trials available now. Certainly, Adstiladrin has been approved for CIS plus minus papillary disease. If we had that in the past, we could certainly use that. Or now with Sunrise 5 opening soon, I think there will be a cohort for this patient to put in the pretzel device for this patient as well, with no residual tumor left behind. So we do have some options. In terms of the erdafitinib, again, it's early in development, and we're going to have trials coming soon that are going to address exactly this. If they have FGFR alterations, I think it's a good way to target that early on so that we have the rest of our treatments available to us later.
So urologists generally, we like localized-based therapy. We're comfortable with intravesical devices. We're comfortable with catheterization and putting a lot of different things into the bladder. But you've shown, very nicely that IO, which started in 2016, and we've had, this an enormous amount of wonderful trial data. Guru, so now that we see IO checkpoint inhibitor indications in metastatic disease, you're going to get into that in your talk, but Sia showed us clearly now in adjuvant setting. We have it in refractory CIS. We're probably going to have it as well in neoadjuvant setting. Clearly, it's being looked at in bladder sparing. The question is, given your background, how do we get uro-oncologists who are dedicated to this comfortable with immune-related adverse events?
Right. So immune checkpoint inhibitors have been in great advance, but it's important to remember that they can have significant toxicities. And although most of the toxicities are manageable with vigilance and patient education, it's important to remember that some of these toxicities can be potentially life-threatening. So most immune checkpoint inhibitor toxicities like the colitis, pneumonitis, hepatitis, you can get any of these itises, which are mostly manageable with vigilance. But remember that the rare neurologic and cardiac toxicities can be potentially life-threatening. So really important to be vigilant.
Well, and the good news is that the grade 3/4s are 15% or less, and 85% of patients don't get. Just a quick additional interest here, especially for urologists, is IO will almost invariably end up being administered not only intravenously, but also subcutaneously. And you can read through the details here. The CREST trial is using, in the BCG naive large trial, global, completely accrued, various arms, as Sia showed you, and similar to the Potomac trial, but it's a sub-Q administration. And then recent positive press release on the top line on nivolumab in metastatic renal cancer. So the notion about a subcutaneous formulation could be very impactful in the throughput of our clinics, hospital-based, clinic-based, at advantages for certain practices and even for patients, particularly geographical issues. I think with the overarching theme of more and more folks staying and getting their care at home. So worth keeping an eye on that. Again, Beacon has great opportunity for our patients to come to clinical trials. We have more clinical trials than we have really high quality clinical trial sites, which is something that we continue to want to work with our academic leadership and get these clinical trial sites developed with rigor within the community so we can answer a lot of these questions. The MDT, for purposes of time, I'm just going to kind of maybe just throw this back over to both of you gentlemen. What have been your learnings, over time? You're in California, you're in Florida, academic community. What are some of the tricks, tips, pearls to making the MDT work better? What have you learned over time? Let me start with you.
Yeah, I think, in the past, it used to be we manage non-muscle invasive, muscle-invasive bladder cancer, and there's this sharp divide, metastatic and adjuvant therapies go to medical oncology. I think in the academic sort of bladder world, there's a lot of mixing and matching now because medical oncologists are treating non-muscle invasive bladder cancer with systemic therapies, particularly checkpoint, and vice versa. We're using some systemic agents now, whether in the bladder or oral therapy, for non-muscle invasive bladder cancer. There's got to be a discussion back and forth. You have to develop a relationship with your medical oncologist, have this close sort of back and forth because the patients are literally going back and forth with some of these trials. So I'm finding that our medical oncologists are becoming more and more familiar with non-muscle invasive bladder cancer, and vice versa. We're becoming more familiar with sort of the locally advanced and metastatic disease because we're sometimes the stakeholders and decision makers in the beginning of whether or not a patient is a candidate for systemic therapy, radical cystectomy, or bladder preservation. So I think learning sort of the whole spectrum of disease for both specialties is really important.
Yeah, I mean, everything that you presented, and then I know Guru is going to present now, it's in the guidelines. So patients are smart. They're going onto websites such as Beacon, and they're getting trusted information. For me, what I've seen is I've got my medical specialist, my medical oncologist, RadOnc, Nuke Meds now. We're all on speed dial.
Yeah.
And then we text, all throughout the day. And then the other issue for me I've noticed is the improvement in tumor boards and virtual tumor boards or hybrid in-person virtual. But Guru, your thoughts?
Yeah, I think that one of the things, I think, as you said, communication is the key to be on speed dial, as you say, with your radiation oncologist, the urologist, the pathologist. I think all of them are important. It's not always that we can get all of these people into the same clinic at the same time. It happens sometimes. But I think the communication is the key so that we are all on the same page and we can get that treatment delivered promptly.
Okay. Fantastic. I think we covered this. I think you can just kind of read through this, but what I find particularly exciting is this wonderful discussion about how do we really sequence these patients, and that more and more data is coming forward, recognizing that many of our patients are not currently getting evidence-based therapy. Goes back to that underrepresentation and how we can do better. SUO, I'm preaching to the choir of people who attend this meeting, but this is how we need to really sort of percolate a lot of this information out into the community. So North Star is always, patient care. So with that, let me turn it over to you, Guru.
Thank you, Neil. So now we will discuss metastatic urothelial carcinoma. And as you may have heard, there have been significant advances and new data presented over the last month. So the current standard in most patients with metastatic urothelial carcinoma is based on this trial, the Javelin Bladder 100 trial, in which patients who had stable or responding disease after 4 to 6 cycles of platinum-based combination chemotherapy received avelumab or best supportive care. And as you can see, maintenance avelumab soon after the chemotherapy improved survival up to a median of close to 2 years with maintenance avelumab. You also see the PFS around 5.5 months. Now, one of the things that's become clear with this paradigm of maintenance avelumab after chemotherapy in sequence is that in the real world, maybe a minority of patients are receiving avelumab just because all of these patients are not going to have stable or responding disease or may fall off because of performance status or comorbidities. Nevertheless, that is a standard established based on that phase 3 trial. Now, what we have done a few years back is combine various PD-1, PD-L1 inhibitors with platinum-based combination chemotherapy in the first-line setting. And these are the 2 trials that have been done before, the IMvigor 130 and Keynote 361. Unfortunately, both of these trials were, at the end of the day, negative. They did not improve survival. Therefore, chemoimmunotherapy did not move into the first-line paradigm based on these 2 trials. However, there was a ray of hope in these 2 trials. So both of these 2 trials allowed either cisplatin or carboplatin as the backbone chemotherapy. So when they looked at these 2 trials and looked at the sub-analyses, it looked like the cisplatin backbone was playing better combining better with the PD-1, PD-L1 inhibitor. You can see the PFS looking a bit better with the cisplatin backbone in both of these trials. So this provides the backdrop for this trial here, Checkmate 901, which was presented at the ESMO conference last month in Madrid. So this trial looked at specifically cisplatin-based chemotherapy, so only cisplatin-eligible patients, phase 3 trial, which compared gemcitabine cisplatin up to 6 cycles versus gemcitabine cisplatin up to 6 cycles, combined with nivolumab, followed by continuation of nivolumab. And nivolumab was given up to a period of 2 years, while the cisplatin gemcitabine, of course, stopped at a maximum of 6 cycles. So the co-primary endpoints for overall survival and progression-free survival in this trial. So this, of course, is the first time that a chemo-IO combination improved outcomes. So this is showing you that the cisplatin gemcitabine nivolumab combination improved overall survival, hazard ratio 0.78, median OS 21.7 months. And also, this combination improved progression-free survival with a hazard ratio of 0.72. Now, what you see is interesting there with the shape of the curve is that the median PFS was somewhat similar, and that's because you see the PFS curves are separating around the 6-month time point. But there is clearly a separation that persists with time, as you can see. So really an improvement in both OS and PFS for the first time with the chemo-IO combination, gem-cis-nivo, only in the cisplatin-based patient population. Now, one of the most interesting findings in this trial is the improvement in response rate, especially complete response rate. You see the overall objective response rate improving from around the 43% range to the 58% range. But what's more exciting is that the complete response rate nearly doubling to around 22%. And the most exciting feature is at the bottom right there. So the duration of complete remission is more than 3 years, the median duration of 37.1 months, which is really exciting and suggests that maybe we are curing many of these patients who achieve a complete remission. Remember, historically, cisplatin-based combination chemotherapy has been known to be the only potentially curative therapy. So this complete remission rate is really exciting based on this data. Now, coming to toxicities with this combination, as you can expect, when you combine a PD-1 inhibitor with cisplatin-based chemotherapy, you can expect some increase in toxicities, some immune checkpoint inhibitor-related toxicities, as well as the toxicities of the cisplatin gemcitabine. So as you can see there, but what was seen with the toxicity profile is that nothing prohibitive came out. So essentially, the toxicities of chemotherapy and toxicities of the nivolumab are seen there in the chemo-IO combination arm, and there was actually only one death from the treatment in both of these arms. So really a tolerable regimen with mostly manageable toxicities consistent with the chemo and the nivolumab toxicities. Now, there is one other chemo-IO trial still ongoing. This is the Nile trial. This is the only one that actually looked at a PD-L1 and CTLA-4 inhibitor combination with platinum-based chemotherapy as the backbone. So this is an interesting trial. It's still ongoing, so we need to wait for the data to see what happens with this trial. Now, the other, of course, very exciting regimen out there is the combination of enfortumab vedotin, the antibody-drug conjugate that targets Nectin-4 and has a tubulin antagonist payload. So this regimen, the EV plus pembrolizumab regimen, is already out there, approved in the US based on an accelerated approval based on this phase 1B and phase 2 data, where you see a response rate close to 70% and the duration of response of approximately 2 years. So based on the response rate and the duration of response, the FDA has approved this regimen in the first-line cisplatin-ineligible disease space for these patients. So we have been using this for the past few months now for some of these patients in this space. Now, of course, what's even more exciting is data from this EV-302 trial. This is a phase 3 trial that enrolled both cisplatin-eligible and cisplatin-ineligible patients, so all comers, first-line metastatic disease. And as you can see there, compared EV plus pembrolizumab versus gemcitabine plus platinum. And one of the key things to remember is that the gem platinum was given up to 6 cycles. Somewhere after the halfway point, they amended the protocol to allow maintenance checkpoint inhibition in the standard arm. Now, the experimental arm, the pembrolizumab was given up to a period of 2 years, while EV did not have a upper limit on the number of cycles that could be given. And the co-primary endpoints are overall survival and progression-free survival. So this is the curve that led to a standing ovation at the ESMO Congress last month. So this, as you can see, for the first time, EV pembrolizumab yielding a median survival crossing 2 years, in fact, crossing 2.5 years, 31.5 months, near doubling essentially of the median survival compared with the gemcitabine platinum arm. So hazard ratios robust, 0.47. And also progression-free survival also was extended with a very robust hazard ratio of 0.45. You see a near doubling of PFS, again from approximately 6 months going to 12 months for EV pembrolizumab. So these data really are expected to be practice changing. This is a huge advance for the field. We've never seen a survival like this or a PFS like this in a first-line trial population. Now, when you look at the objective response rate in this trial, again, that also was impressive. As you can see, the objective response rate improving from around 44% with the chemo arm to 68% approximately for the EV pembro arm. And look at that complete response rate, 29% approximately complete response for EV pembrolizumab is also very impressive. Now, the duration of response has not been reached in the experimental arm. So really, we need to wait and see what those durations look like. So really very impressive data for all of these endpoints with EV pembrolizumab in an all-comer first-line population. Now, this is the toxicity slide for EV pembrolizumab versus gemcitabine platinum. As you can expect, the toxicities seen with EV pembro include those of EV and pembrolizumab. Remember the skin rash and the neuropathy from EV. The skin rash can be quite early, so we have to be, again, very, very vigilant with this drug. But these toxicities are consistent with what was seen in the previous phase 1B and phase 2 trials, so nothing new here compared to what we've seen before, but clearly the toxicities have to be monitored, and you have to be vigilant along with your patient education when you're giving patients these drugs. One of the key things is that in this trial, the EV pembrolizumab combination was given for a median of 12 cycles. So that's actually a lot of cycles that could be delivered in this trial. So that I found interesting, actually. So are there other ADCs that we have? So one of the class of ADCs that is emerging is ADCs targeting HER2. As you can see, trastuzumab, deruxtecan look very interesting for the response rate of close to 40% in HER2 expressing patients, even higher in HER2 3+ expressing patients. This is the pan-tumor basket trial with this drug, so we need to wait and see. Potentially, this drug could get an accelerated approval based on this these data, so we need to wait and see. Disitamab vedotin is another HER2 targeting ADC that looked very interesting in combination with a PD-1 inhibitor, and is actually already in phase 3 a trial looking at comparing this combination with gemcitabine platinum. Now down there you see sacituzumab govitecan. So this is a TROP2 targeting ADC with a topoisomerase 1 payload, SN38. This drug is of course already approved by the US FDA. This is accelerated approval based on the response rate of around 28% with a median duration of response around 8 months. So this drug is a great addition to the therapeutic armamentarium because this payload does not have the neurotoxicity which we see with some of the other drugs we have out there. So this is clearly a great addition to the armamentarium and is approved in the post-platinum and PD-1, L1 inhibitor space. Now, one of the questions that arises is with all of these data for early PD-1, PD-L1 inhibition in the adjuvant space, potentially we will have a neoadjuvant chemo IO EV pembro combination also emerging over the next few years. Now, what impact does this have on these first-line regimens, the cis-gem, nivo, EV pembro if patients have already received adjuvant nivolumab, let's say. So this needs to be hashed out. We don't quite know how to deal with this. Of course, if a patient's been discontinued from nivolumab for a significant immune event, that's a different story. You don't want to expose such a patient to an immune checkpoint inhibitor again if the patient had a really serious immune adverse event. But whether progression on the adjuvant therapy versus after the adjuvant therapy is complete, if that makes a difference to whether you would do EV pembro, Gemcis nivo or not, that remains to be seen and remains to be studied further. Now, one other class of drugs that's out there is erdafitinib. Erdafitinib is a pan-FGFR inhibitor, oral TKI. And this, as you know, is an important agent for this class, this group of patients that have the FGFR3, FGFR2 activating mutations or fusions, which is approximately 15% of patients. And so we should always look for this mutation or fusion in advanced disease patients. Now, erdafitinib is approved based on a non-randomized phase 2 trial in post-platinum patients with metastatic disease, based on this response rate of approximately 40% and the duration of response. Now, however, we did not have a phase 3 trial yet that led to that initial accelerated approval. So now we have data from the Thor trial shown here. This is a phase 3 trial that compared erdafitinib versus chemotherapy in post-PD-1 L1 inhibitor treated patients, and had a second comparison of erdafitinib versus pembrolizumab in post-chemo patients in the second-line setting. So earlier at ASCO this year, this comparison was shown for erdafitinib versus chemotherapy in post-PD-1 L1 inhibitor treated patients. And as you can see, this trial was stopped early based on the interim analysis showing an improvement in survival to close to a year with erdafitinib compared to chemotherapy. And also there was an improvement in progression-free survival. The objective response rate was consistent with what's been seen in the previous phase 2 trial, which is approximately 45% response rate. So really, these data are expected to hopefully get erdafitinib into the full approval space, so we need to wait and see. Now, the other comparison that was presented a little bit later at ESMO last month was this comparison of erdafitinib versus pembrolizumab in the Thor trial, the second comparison, in post-chemo patients. This was interesting because what this comparison showed is that the survival was not extended by erdafitinib compared to pembrolizumab. Remember, this is all FGFR3, FGFR2 activating alterations. The interesting finding was that the response rate was clearly higher for erdafitinib, and the PFS was higher. However, the duration of response with pembrolizumab was much longer. And also interestingly, you see that pembrolizumab is actually active in this group of patients, and there were a lot of doubts about whether PD-1 inhibitors retain their activity in this population, but clearly it looks like the response is retained at around 21% for pembrolizumab in this patient population. Now, erdafitinib has been known, of course, being a pan-FGFR inhibitor. It's a TKI. It does have toxicities. We know the hyperphosphatemia is a class effect. And as you might know, in the trials, the erdafitinib of advanced disease trials, the erdafitinib was escalated from 8 milligram daily to 9 milligram daily if hyperphosphatemia was not achieved 5.5 by around 2 weeks. So that really, they were trying to guide the dosing based on the pharmacodynamics of this drug. So hyperphosphatemia is important, a low phosphate diet is important, and addressing severe hyperphosphatemia is important with phosphate binders. The eye toxicities are important. As oncologists, we're not used to eye toxicities that much, especially because this one is a posterior eye toxicity. This is a retinal toxicity. It can cause a central vision defect. So really, you have to get your ophthalmologist on board, and ophthalmology exams monthly for the first 4 months, and then go out to every 3 months. So really have to be vigilant about the eyes. Sometimes it's tough to get in to see an ophthalmologist. So I've used something called the Amsler's grid. It's a grid that you can print off and ask the patient to look at it and let you know if they see any distortion or waviness in the grid, the lines of the grid. So that's an important tool you could use in the clinic yourself. course, stomatitis and diarrhea can be seen with this agent. One of the things I will highlight is that despite these toxicities and the dry skin and the nail changes, I will point out that these toxicities are manageable with vigilance and patient education. These are mostly not life-threatening toxicities, I will point out. So really manageable and clearly a nice addition to the therapeutic armamentarium for this 15% group of advanced disease patients who have these alterations. So really the take-home points from this discussion of metastatic disease is that while at the moment the Javelin paradigm is established for most first-line disease patients, the gemcitabine platinum for 4 to 6 cycles, followed by maintenance avelumab in patients who are responding or stable, the fact is that in the real world, it's difficult to get to avelumab because of a number of reasons, progressive disease or comorbidities. So really these upfront, more aggressive combinations, EV Pembro, Gem-Cis Nivo for cisplatin-eligible patients, I think are going to be a practice changing based on the recent data. We need to, of course, wait and see what the regulatory agencies say. Both of these regimens produce high responses, early responses. The responses seem durable. So really, I believe that these two regimens will bring a huge impact to the first-line space. I think there will remain a space for the Javelin paradigm of maintenance avelumab in select patients who are not fit for aggressive combination therapies. But I think these two regimens are something to consider in the near future, I think, while we await regulatory decision-making. Of course, remember that HER2 targeting ADCs are being investigated vigorously, and I think they will also bring an advance in the near future. Sacituzumab govitecan is already out there. The TROP2 targeting ADCs is not a neurotoxic drug, so it's a great addition to the armamentarium and does seem to retain activity even after enfortumab vedotin exposure. And going forward, we don't know the impact of adjuvant nivolumab or potentially neoadjuvant EV Pembro chemo IO coming into the space. We don't know the impact of that on first-line immune checkpoint inhibitor incorporating regimens like Gem-Cis, Nivo, EV Pembro. So we need to study that further. Remember that despite all of these advances, we are not curing the vast majority of patients. So clinical trial accrual needs to be the main focus, and always think of clinical trial first before you start thinking of the standard regimens out there you can use in the clinic. Thank you.
Well, thank you, Guru. That was great. This is such cutting-edge material. Just a quick show of hands. Did anybody here attend ESMO? See some of these presentations? Okay, fantastic. I mean, the 901 has a New England paper. Vander Heiden is the first author. The 302, the EB302, hasn't been published yet, but as Guru said, it got a standing ovation. So remarkably practice-changing. Antibody drug conjugates for ADCs are here. They're kind of their mainstay now, and I think uro-oncologists need to be fully aware of that. Let's go to a case, and we've gotten some really good questions already that I'm going to ask you, Guru, and they're kind of focusing around this ongoing controversy is the 901, Nivo chemo versus Pembro or IO-EV, Pembro EV. So we'll get to that. But here's a 66-year-old, gross hematuria, has a bladder mass, gets a resection. Let's assume this is clearly T2 disease. He's got adenopathy, retroperitoneal, pelvic, good, reasonable renal function, reasonable performance status. And here's the thing, I'd love to hear some thoughts on this, is mild neuropathy. Maybe you can comment on that, Guru, what you're doing now to assess for neuropathy at baseline moving forward. And these are kind of looking at some of what we've oftentimes called the Galsky criteria. In addition to renal insufficiency, low creatinine clearance or GFR, contraindications to chemotherapy consistent with hearing impairment and baseline neuropathy. Alterations, IHC status at PDL, etc. No FGFR alterations for this patient. So given everything you just said, Guru, what would you have this patient now think about frontline metastatic urothelial cancer?
Yeah, thank you, Neil. So again, clinical trial, if a clinical trial is available, but in the absence of a trial, the current standard for this patient seems to be cisplatin eligible, does have mild neuropathy as shown there, but grade 1 neuropathy is not an absolute contraindication to cisplatin. The renal function is 60 estimated GFR, so that makes this patient cisplatin eligible. So while the Javelin paradigm of cis-gem, or you can certainly use your favorite cisplatin-based combination, followed by maintenance avelumab, while that is the current standard, I think that what we're going to see in the near future is EV pembrolizumab or gem-cis nivolumab in this space. Now, I think that they're both valid options. The pros and cons are EV pembro clearly had a huge median survival, 31.5 months response rate, 29% complete response rate. One thing that I was really impressed by with gem-cis nivo is that there's a finite duration of gem-cis up to 6 cycles, and then it's the nivolumab alone. So I do believe that the gem-cis nivo regimen offers, will play a big role in select patients, especially someone like this with lymph node only disease that we know historically is potentially curable with cisplatin-based combination, especially given that the finite duration of chemotherapy gives this patient, I think, a better quality of life when the nivolumab alone is ongoing, as opposed to the EV pembro regimen. While highly active and a huge advance for our field, the EV was given until toxicities or progression, and the neuropathy is a significant toxicity with EV cumulatively. And therefore, I believe that both of these regimens are options, and especially in a curable patient like this with lymph node only disease, I would strongly consider gem-cis nivo as a valid option, and I would discuss both these options with the patient.
So, so I appreciate that. I think it's going to be a great discussion of tumor boards, comparing and contrasting 302 and 901. These are provocative, really important studies. But questions are coming up on my pad here, but also they're really, we see them here. So we talked already a bit about the importance of immune-related adverse events. I mean, there's, 25 different indications right now across multiple tumor types for pembrolizumab. So medical oncologists are very familiar with this. This is absolutely essential that uro-oncologists are familiar with this and not, worried about their ability to work together. But let's go to the skin rash. And, other than dermatologists, medical oncologists, no one likes dealing with rash. But it's not that complicated, but you do see more rash with EV, and you do see neuropathy. And some of the other ADCs, for example, SG, you can see issues regarding diarrhea and anemia. So the questions I have for both of you is, what's also popped up here is, how are you educating patients on neuropathy and skin rash? And then a question that's also come in here is the use of erythropoietin for anemia. So, Guru, you want to take a first stab at that?
Well, the typical feature of the EV skin rash is it's very, very early, usually within the first month. It can be as early as within a week, in fact. So most of the rash is manageable with holding the drug, interrupting, or dose reductions. It's, however, a very small percentage can be life-threatening potentially. Stevens-Johnson syndrome has been seen. And so the really key thing there is patient education for patients to be able to reach you easily and be able to go to the ER if it's a significant rash in the middle of the night. But I can tell you that there's a long learning curve here, and we still are not great at catching a rash at the right point in time and treating the rash, but that has to be done. The ICI toxicity, pembro toxicity, of course, can also be at any time. The median time to onset of immune events tends to be around 2 months, but it can be seen as early as a week to 2 weeks. So really, and even as late as beyond a year. So you have to always be vigilant.
I think one other thing I wanted to point out, it's very interesting, EV targets Nectin-4, as we all know, and there's Nectin-4 in the subcutaneous, in the skin, essentially. And there's some evidence, if I'm not wrong, Guru, that getting a rash may actually be representative of a better response to EV. So, educating the patients that this is not necessarily a bad thing, provided it's mild, and educating them ahead of time, I think is important.
Well, I just think these are really important for all of us to recognize that as we get breakthroughs, we need to be very comfortable and knowledgeable with patient expectation, patient education, and managing these new adverse events of interest. So, the fact that we're getting into precision-based therapy right now, multiple new classes of mechanism of action, and isn't that always the key, combining whether it's a chemotherapy-based intravesical or systemic, but now FGFR biomarker assessment, different ways to deliver therapy with improved dwell times into the bladder, combining ADCs and IO, or even ADC or IO and chemo, neoadjuvant, adjuvant. This is where we're making such great advances. I mean, the fact that Guru showed data that patients are living out to 3+ years, where historically metastatic UC patients were looking at 7 to 15 months, I think is quite remarkable. And really putting the burden on all of us who take care of these patients to make sure we're doing it in a multidisciplinary way. So I think we're pretty much at time. Thank you all very much for coming. Guru, Sia, thank you so much. Great presentation.
Neil. Thank you.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/XJV860. This activity is supported by independent educational grants from AstraZeneca, Bristol Myers Squibb, Janssen Biotech Incorporated, administered by Janssen Scientific Affairs, LLC, and Merck Co. Incorporated.